This radiology report was wrong. The radiologist made the conclusion that the palpable abnormality in the right breast was demonstrated to be due to a cyst, but instead it turned out to be something else altogether, which would have been harmful for the patient if it were left undiagnosed. Stay tuned to find out how the issue was corrected. In this video, we will identify, firstly, the reasons for this misdiagnosis on imaging, secondly, how the diagnosis was made in a timely fashion and how you can help yourself if you encounter such a situation. This patient K came to see me for a lump in her right breast. Having had surgery to the left breast previously, she was very prompt to see a doctor about her symptoms. These are the two views of the mammogram for her right breast. And here are the ultrasound images of her right breast lump, one through a horizontal axis while another taken in a vertical plane. You will recall that this was reported to be a cyst. Why was that? This is because the lesion had many features which were similar to what would be expected of a cyst. In this teaching chapter by Professor Berg and her colleagues, it is stated that cysts may appear in these forms on imaging. The phrase used is partially circumscribed, partially obscured masses, or PCPO for short, on mammogram. She says that ultrasonography is appropriate to evaluate the dominant palpable mass, and targeted ultrasound, in the case of this example, confirmed a benign simple cyst. While expounding on tips to enable clearer visualization of the lesions detected, the authors proceed to say that a sonographically simple cyst with the classic appearance can be dismissed as a benign finding. Let's go through a side-by-side comparison. The yellow arrows point to what cysts are expected to appear like on mammogram, according to this educational article. The blue arrow points to the actual mammogram image generated by K's lump. As you see, they appear similar. On ultrasound examination, a cyst is expected to produce an image indicated by the yellow arrow, while the blue arrow highlights the image that K's palpable breast lump actually generated. Let us look at the features listed in the teaching article and how it matches with K's image. The second descriptor is anechoic, meaning that the image appears totally black without any white or gray shadows apparent within. The mass is oval with imperceptible wall and posterior enhancement, which is the brighter white area deep to the lesion. So this image had almost all the features of the classic appearance of a cyst, and in this article it is stated that such a lesion can be dismissed as a benign finding. A radiologist who has read this article may be tempted to consider this a cyst and dismiss it as a benign finding, which was what K's radiologist did. This was the reason for the misdiagnosis. In K's case, how was delayed diagnosis avoided, seeing that her radiologist dismissed the finding as a cyst? Let us revisit the characteristics of K's lesion. Careful reevaluation provides the answer to how misdiagnosis may be avoided. The first feature on the list was that the lesion should be avascular. However, this was not assessed in her imaging. Vascularity, or the presence of blood flow within the lump, is done through a special Doppler function which was not turned on in this case. In addition, there was some irregularity along this wall indicated by the blue arrow, which may have been overlooked. This, together with the knowledge that a palpable mass reported as a cyst on imaging had a 4.4% chance of being cancer, increased the level of suspicion that this lesion may not be benign. 4.4% may not seem like a very high probability. However, it is above 2%. A 2% risk of malignancy or less is considered appropriate for not performing a biopsy in favor of observing the behavior of a lesion with imaging surveillance. For a lesion with a risk of 4.4%, biopsy should be offered as it is at least double the accepted risk for lesion monitoring. Also, it was my assessment at the time that this risk was likely to be higher than 4.4% because of the irregular wall. K was agreeable to undergo a fine needle aspiration biopsy. The biopsy revealed that carcinoma cells were present within the lesion. In summary, this was the point of diagnosis that she had breast cancer. In spite of the radiologist reporting that this was a cyst and recommendation from an article in a medical journal that lesions diagnosed as cysts on imaging can be dismissed as a benign finding, this patient had a timely diagnosis and treatment through careful reassessment of the imaging. In Kay's circumstances, it is my belief that these points led to a timely diagnosis. Firstly, careful independent assessment and reevaluation of imaging. Secondly, correlating the findings on her clinical examination with her radiology report aided in her diagnosis. The third critical point was not to assume that the radiologist is correct. Fourthly, a doctor needs to have enough courage to make recommendations which are different from standard teaching if there is doubt. Lastly, I have to emphasize that the patient must be willing to accept the path of biopsy. Do not forget that the majority, or 95.6% of women with similar findings, will be diagnosed with a benign lesion, and some may feel that they had an unnecessary procedure if there was no cancer. The last question to address is what you can do to help yourself navigate the narrow space between over-biopsy and delayed diagnosis. Why do I bring this up? It is relevant for women who undergo breast screening. Breast screening is a process for the early detection of breast cancer. It has been shown that women who are exposed to screening have improved survival compared with those who do not undergo screening. However, it is important to note that not every lesion seen on imaging during a screening episode is cancer. As you would recall, there are occasions when a woman may have multiple masses detected bilaterally or within both breasts. The majority of these lesions are benign. To understand with certainty the nature of the lesions, a biopsy is required. This involves a procedure to remove tissue from the lesion to send to a pathologist for examination under a microscope. It is only then that a definitive diagnosis is made. When a biopsy is performed and the pathology result is benign, it is referred to as a false positive biopsy recommendation. While the goal of screening is the detection of early-stage breast cancers, there is the need to balance this against too many false positive recommendations for biopsy. Unfortunately, the objective of early detection of every cancer is in conflict with reducing the number of biopsies. So, a probably benign assessment was introduced where imaging surveillance is recommended rather than biopsy for lesions at sufficiently low risk of being cancer. This threshold is set at 2%. But setting 2% as the risk threshold for biopsy means that potentially 2% of women can be expected to have a delayed diagnosis. Speak to your doctor if you do not wish to accept this 2% risk. However, there is another risk that a patient would need to bear in mind if she cannot accept this 2%. We will discuss this soon. But at this point, I wish to state that Kay is not the only patient who forms the minority where the image of her cancer had features which overlapped with a benign appearing lesion. This patient had 2 lumps, one in the right and the other in the left breast. The one on the right had the classical features of breast cancer with irregular margins and posterior acoustic shadowing, and the radiologist reported this lump to be suspicious for malignancy. However, the left breast lump was reported to be a simple cyst. On biopsy, both lesions were diagnosed to be cancer. So you may ask, if there are enough of these cases where what is reported as cysts on imaging turn out actually to be cancer, why do doctors wish to reduce the number of false positive biopsies? It is because biopsies are not totally innocuous. The most common technique used is the vacuum-assisted breast biopsy. While it is minimally invasive, it is not without complications. This chart is for those who are statistically inclined and provides a list of the potential complications which may occur with vacuum-assisted breast biopsy. In simpler terms, complications like hematoma formation, a result of bleeding, may occur in 8 to 9% of women who undergo vacuum-assisted biopsy. There may be other problems and occasions when complications are serious enough to warrant surgery. This is the main reason why doctors do not recommend a biopsy for every lesion detected in a screening setting. So, in summary, to reasonably prepare for our breast screening journey from age 40 to 70, we should decide for ourselves the degree of uncertainty which we are able to accept, and compare that against the risk of post-procedural complications we are able to tolerate in the event the biopsy result shows benign tissue. Unfortunately, it is not possible on a population basis to ensure that every woman who undergoes screening will achieve early diagnosis at the first biopsy. In Kay's case, she was not willing to accept a 4% risk of uncertainty and agreed to undergo a biopsy. She made the right decision for herself and later underwent breast conservation treatment. Finally, these are the issues you can discuss with your doctor. It's what I always discuss with my patients when a decision is made for breast biopsy. That said, every situation is unique, and since the content in this video is solely intended for educational purposes, may I encourage you to see your doctor to understand your specific clinical circumstances and the best treatment plan. Thank you for staying until the end of the video. If you have found the information helpful, kindly click the like button, share, comment, and subscribe. There are many other videos in this channel on the surgical treatment of breast cancer. I hope you will join me there as well. Until we come together again, take care.